generation devices. So we've done new trials, new devices, and now new indications. Bhabra from halfway between Wolverhampton and Birmingham is going to talk to us about valve-in-valve TAVI.
Thank you, Neil. I'll try to go very fast. I think I only have about 15 minutes before the next session starts. I'll probably skip through some of the stuff I've got on here. Can I just ask before I start, how many people in the room are actually involved in TAVI implantations? Hands? Quite a few. Okay, great. So just to summarize what I'm going to talk about, I'm going to talk mainly about valve-in-valve therapies for the aortic position. I will go through indications, patient evaluations, and procedural tips, and then a quick run through some of the published results. I'll touch on mitral and tricuspid valve procedures. I'll show you a couple of apps that are available, and lastly we'll look at some of the implications that all of this has on our current surgical practice. So to start with, TAVI within aortic bioprostheses. So it's estimated that worldwide there are now about 200,000 surgical aortic valve replacements performed annually, of which the majority now are bioprostheses rather than metal valves. There is a tendency to use bioprostheses in ever younger patients, and we know that the durability is limited, so 10 to 20 years at best. So looking ahead, the numbers of patients who will come back with failing bioprostheses will increase as time goes on. So what are the ways in which these bioprostheses might fail? Well, you can get stenosis or regurgitation or a mixture of the two, and the definitions of these are available in the European and American valve guidelines. How do the valves fail? Well, you can get calcification, and there are a number of theories about why that happens. You can get pannus, which on the whole is a good thing because it covers suture materials and sewing rings and makes the material less thrombogenic, but the pannus can then creep onto the valve itself and start to obstruct it. As a result of the calcification, you begin to get increased stresses on the valve leaflets, and at the shear points you can get tearing of leaflets, and this usually results in fairly acute severe aortic regurgitation. And finally, you can get thrombosis, which is rare with bioprostheses, but endocarditis, which occurs in about 1.2% of patients per year. Clearly, you can't treat acute endocarditis with a TAVI, but you can if it's adequately treated. So what then are the indications for TAVI? And I'm talking really about indications over and above the standard indications. So reoperation, of course, is still the standard of care. If at all possible, patients should have redo surgery and have a new valve put in. But in some patients, clearly this will be at increased risk. There are patient factors, so elderly patients, frail patients, patients with comorbidities. And then there are operation factors as well. So if you have patent bypass grafts from a previous operation, especially mammary bypass grafts, if you have a hostile sternum, so if after the first operation, if you had a major sternal infection, for example, then re-entry can be quite hazardous. And of course, if you have a calcified aorta, then for technical reasons, surgery might be high risk. And TAVI provides a less invasive approach for these patients. So just by way of an example, this is a patient who has previously had an aortic homograft, and you can see from the CT that all of this is made of bricks. This is a patient that we did recently, just last month. So he was young, he's otherwise fit and well, so his Euroscore will be quite low. He had a homograft root replacement in 1998 and came back to us with heart failure with severe acute regurgitation and class 4 NYHA symptoms. And you can see from these CT images that the whole of the root is calcified. And I've never done a redo for these patients, but I've seen it being done, and it's pretty messy. So we offered TAVI to him after a lot of discussion, just to confirm that the aortic regurgitation was severe. So you can see the calcification here. And we used a core valve. You can just see the various stages of deployment here. And that was the final result with trivial regurgitation. So a 1.25 hour procedure in the cath lab as opposed to probably an all-day operation. And this is the more common patient. So this is a guy we did a couple of years back, a fairly typical 88-year-old frail man who had a bioprosthesis 10 years ago. And he presented with severe aortic regurgitation due to bioprosthetic failure, and he also had renal dysfunction. So after going through the MDT, he was put forward for TAVI, and again, I'll just show you some brief images of a core valve being deployed. That's the final deployment, and as you can see from the aortogram, there's an excellent result with hardly any regurgitation. And these patients get extubated and are having their lunch. So what about contraindications? Well, again, I'll focus on specific contraindications. As I said, if you have active endocarditis, you wouldn't do this. If there is concomitant paravalvular regurgitation, then you need to think very carefully, because putting a TAVI device inside the old valve isn't going to make any difference to that. And you might need to worry a little bit if there is a detached leaflet in terms of where it's going to go, the possibility of coronary ostial obstruction. Sizing is very important, and I'll come to that next, but in terms of planning for the procedure, it's very important to be absolutely sure what prosthesis was put in the last time. It can be difficult. They may have had the surgery at a different hospital, but you've got to go to great lengths to get hold of operation notes and so on, to know exactly what model it was and what size it was. And then you can correlate that information from your own imaging. You can look up the internal diameter of the device using charts or using an app, which I'll show you later. But you need to confirm it. You need to do your own measurements. So you've got to use especially CT and also echo to see what sizes you measure as internal diameter. And you have to remember that it's not just the stent of the valve, but you have to correct it for leaflet tissue, because the leaflets will be pushed aside and will take another millimeter or so of space inside that valve. And for stentless valves, just to clarify the way they're labeled, so a stentless valve is labeled according to its outside diameter, whereas a homograft size is labeled on the internal diameter. So for the procedure itself, for most patients, you don't need to predilate the bioprosthesis. And the critical thing is that compared to deploying a TAVI valve in a native annulus, you get much less friction between the device and the annulus. So you get much more movement. So if you're using a sapien valve, you've got a really rapid pace and let the blood pressure drop right down before you deploy it. If you're using a core valve, you have to make adjustments. Initially, when you begin to deploy the valve, it'll tend to dive into the ventricle. And then once it's begun to flare and you have some contact with the bioprosthesis, and as the valve starts to function, there's a tendency for the valve to be pushed out. So you have to anticipate these things and make appropriate corrections. And use pacing. Pacing is very important to give you a steady cardiac output with no beat-to-beat variation. And if you increase the rate on the pacing, you can drop the cardiac output down while you deploy. So when you're doing a TAVI within a stented bioprosthesis, you need to be familiar with the different valve types and what markers they have. So there are some devices which have markers at the tops of the crown. There are some which have a radio-opaque marker at the sewing ring, and some of them, the marker goes well below the sewing ring. So you need to be sure that you know what you're looking at. Stentless bioprostheses are more difficult. There are no radio-opaque markers. Often there is very little leaflet calcification, so you don't really have much to go on. And you have to rely pretty much on using a correctly positioned pigtail in the coronary, in the aortic sinus, and do lots of injections of contrast so that you know exactly where the leaflets are before you deploy a valve. Other things you can do, you can use two pigtails, one in the left coronary sinus and one in the non-coronary, to give you a better idea of where the leaflets are. And also, if you're concerned about coronary obstruction, you can put a wire in the left main stem to make sure you're not going to occlude that. A word about valve gradients. So typically, the gradient you end up with after a TAVI procedure is going to be higher than with native valves. You're limited by how big the original valve was. So if somebody put a small valve in last time, you're not going to make it any better, you're only going to make it worse. So if there's pre-existing patient-prosthesis mismatch, you will make it worse. This is partly alleviated by the valve design. So this is the core valve and this is the sapien valve. The difference is that the core valve, the valve itself, is supraannular. So at the level of the bioprosthesis, you only have the stent and the skirt, whereas with the sapien, the valve itself is intraannular, so it occupies more space within the bioprosthesis. So the gradients tend to be higher within a sapien. I'll just skip quickly through some of the evidence. There are no randomized trials. There is a global registry as well as some small series and lots of case reports. So this is the main source of what I'm going to talk about. So this is Circulation 2012, the Global Valve-in-Valve Registry, which included 202 patients from 38 centers across the world. And this data is mostly retrospective, and clearly there are limitations with that. The median time since the most recent valve replacement was 9 years. The patient's mean age of 77, the logistic Euro score of 31, so that's pretty high. And looking down there, as you would expect, the majority of patients are in class 3 or class 4 NYHA. 15% have had more than one previous valve replacement. The types of stented valves, so stented valves 155 out of 202, and all different types of bioprostheses, and 47 stentless valves. 42% of patients had primarily stenosis, 34% regurgitation, and 24% mixed. 124 of the patients had a core valve deployed, and 78 patients had a sapien valve. Both of these devices now have CE approval for this indication. So the procedural results, the procedural success, and I won't dwell on the definition of that, but it's 93%. The need for a second TAVI valve deployment is 8%, and there were 7 patients who had coronary ostial obstruction, and 4 patients required emergency surgery. 30-day results, the mortality is reasonable for these patients, very high logistic Euro score, mortality of 8.4%, 2% stroke rate, and the permanent pacemaker rate was quite low, only 7%, compared to what we've heard earlier on. The valve gradients were higher than you've seen. So previously you've looked at the results of all the studies where the valve gradients were in single figures. Here we're looking at a peak gradient of 28 and a mean gradient of 16. 5% of patients had more than 2+ aortic regurgitation, and as you can see down here, the majority of patients were in NYHA class 1 or 2 at 30 days. So just to demonstrate here what I said earlier, with the core valve, the valve gradients were not as high as with the sapien. I'll just skip through that. The coronary ostial obstructions, 7 cases, of which 2 were in patients who previously had a Sorin Freedom stentless valve, 3 in the mitral flow, and the rest in the various other devices. The risk of coronary obstruction is increased by if you have a tall leaflet length, if you have external mounting of the leaflets around the stent, as is the case in the mitral flow, so these leaflets are more likely to obstruct the coronary artery, and with stentless valves. And the 12-month survival for this registry data was 85.8%, with 87 patients at risk. The results, both in terms of the hemodynamics and the symptoms, were maintained out to 12 months. So that's the registry, and there's 4 other series that I could find between 25 and 47 patients, and the results are pretty much in keeping with the registry data. So in summary, valve-in-valve is a treatment which is effective and seems to be reasonably safe for these patients. Pre-case planning is critical. Deployment is more difficult than a standard TAVI. And you have to remember that post-procedure gradients will be higher than we're accustomed to seeing. So just to touch very briefly...
Sorry, I'm running out of time. I think we might have to leave the mitral valve-in-valve.
Okay.
You got a sort of final
I only have 2
conclusion.
or 3 slides left, to be honest.
Okay.
So you can do mitral valve-in-valve in a bioprosthesis, usually transapically or sometimes transatrially. So this is just showing a transapical sapien. And you can also put a sapien valve inside a previously repaired valve. This works better if the previous annuloplasty ring was non-rigid and if it was complete. And I think this is a group of patients that we're going to see more of in the future, so failed repairs coming back. There's one report of about 14 cases, so not much in the literature. You can do this in the tricuspid position as well, using either a sapien or a melody valve. You can put 2 valves in a patient, aortic and mitral, or mitral and tricuspid. And you can put TAVIs inside old TAVIs in failed devices. So there's case reports of that. There is a valve, also I would just skip through these. There is a valve-in-valve app for aortic and mitral valves, which is very useful, worth looking at. It's free. And finally, I was just going to bring up this slide, which was, I think there'll be no time for the discussion, but really the question is whether we need to rethink what we use now in our conventional surgical practice. Should we rethink when we use bioprostheses and when we use mechanical valves? And should we reconsider what kind of annuloplasty we use for repairs, bearing in mind that in 15 years' time, if you need to put a bioprosthesis in, you want to get a good result from that. Thank you very much.
So I apologise again for giving you such a short time. Any burning questions? I know many of you will want to go off to other sessions. I think that last slide there, as you walk out, I think all surgeons need to think very carefully about what valve they implant the first time round. So thank you very much for attending the session and enjoy the rest of the day.